TopMedTalk.
Well, hello and welcome to TopMedTalk Down Under. I'm Kate Leslie and I'm here with my co-host Andy Cumpstey. And we're at the Australian and New Zealand College of Anaesthetists and Faculty of Pain Medicine annual scientific meeting, which this year is in Brisbane in the north of Australia. We're at our booth in the healthcare industry exhibition and it's buzzing, Andy, after some fantastic sessions this morning.
There's a real buzz in the room, isn't there, Kate? It's great to be back in person and see everyone kind of milling around. Well, it's actually a really massive but also really busy exhibition hall. There's the huge coffee queue forming every break next to us with the coffee machines, and all the sponsors are getting lots of people around their stands, which is fantastic. It's really great to see everyone here enjoying the conference. And
tonight we've got the healthcare industry reception, where straight after the last session, everyone comes in to have entertainment and more networking with the healthcare industry. And that's great. And then that's followed by the foundation event. So we've got a heavy schedule today, Andy.
It's not just the science, it's all about the social at the meeting, isn't it? It's about connecting and meeting everybody as well. I think that's really important for these in-person events.
Totally. So speaking of great people to network with, we have two wonderful guests today. We're going to talk about global health. So first, Chris, I'll get you to introduce yourself.
Thanks, Kate. So my name's Chris Bowden. I'm a consultant anaesthetist, now living and working in Queensland on the Gold Coast, having spent the first 20 years of my career in Melbourne. I'm a little bit different. The reason why I have an interest in global health is I actually grew up in the Pacific, in Vanuatu. And so my desire has always been to get back into work in that sort of environment. And so now I've had roles in the ASA as the chair of the Overseas Development Education Committee.
That's the Australian Society of Anaesthetists, yes, for our international listeners.
Yes, absolutely. And I've just recently stepped down as chair of that committee, and I've taken up a role as our council representative on the WFSA, the World Federation. And I'm also involved in lots of teaching and education, having been in the Pacific for about 20 odd years or so.
It's been amazing. I first met you in Kota Kinabalu in Malaysia, where you were teaching on a course.
I remember that well.
It was a long time ago.
It was good fun.
It was. And Rob McDougall, tell us a bit about yourself.
Oh, Kate, I'm a paediatric anaesthetist based at the Children's Hospital in Melbourne, and I became interested in global health through my interest in education, and also I had the great Kester Brown as my first head of department, who strongly encouraged me to go firstly to the Pacific, where I've done had extensive experience teaching and some clinical work as well, primarily through the Australian Society of Anaesthetists Overseas Development and Education Committee, also through organisations such as the Primary Trauma Care Foundation, which took me to places like Mongolia and Vietnam, which is one of my favourite places to visit. I too have been involved in the World Federation of Societies of Anaesthesiologists, having served terms on council, and I'm currently a board member of a fantastic NGO that's devoted to safer surgery and anaesthesia called Lifebox.
Fantastic. And just so everybody knows, the College of Anaesthetists is involved in overseas aid as well.
And it is, the College of Anaesthetists is a fantastic contributor. The great news is we've got two societies, New Zealand and Australia, the college and a number of other organisations who work together, and the college has done tremendous work, particularly in PNG. But without the college, I think the state of anaesthesia in our region would not be where it is beginning to get to now.
So, Andy, they've got some hot topics to talk about, I think.
They have. And I was going to say, I'm fascinated by this topic. So I'll confess, I've not done anything like as much work globally as I would have liked to during my training. But you've hinted at some of the work you've done, but are you presenting on some of these topics?
We were asked to run a couple of workshops on Friday. The topic was work opportunities, where you can go and how to prepare. A shortened down version of a 5-day course that we've been running for about 25 years.
Wow.
Called the Real World Anaesthesia course. And it used to be called something very different. It used to be called the RSDC-DCA, remote...
It's really catchy.
remote situation, difficult circumstances, developing country anaesthesia course.
Well done.
And we decided to change the name of the course about 10 years ago when it was pointed out to us by a surgeon from the Solomon Islands that we don't live in the real world where we come from. 80% of the world's population live in low middle-income country environments where they have limited access to safe surgery anaesthesia. And so we decided that we would change the name of the course as such, and that course now runs...
Chris, it was a provocative move at the time, and you did get some negative feedback.
That is true.
You want to talk about that?
This is a family podcast, Rod.
But as RWAC is a much easier acronym to
just remind us again what that stands for, people listening at
real world
anaesthesiologists.
Yeah, and it runs in 3 cities in Australia and New Zealand. It rotates between Darwin, Christchurch, and where I was working at Frankston in Melbourne. The plan obviously is that if I'll probably run it on the Gold Coast next year, and it's a course that really focuses on giving anaesthetists from Australia and New Zealand who are interested but maybe haven't gone and done this sort of work, a 5-day intense opportunity to develop some understandings as to what the challenges might be and how to prepare. And Kate was pivotal a number of years ago because we also teach a low acuity anaesthesia delivery mechanism called draw-over, and Kate was the then president of the college, and she very kindly came down to a small hospital that I worked at, and we worked together for a morning, and Kate learnt the art of draw-over. And I do remember very clearly you said at the end, this is just so simple and yet so elegant, which is what it was all about.
And so scary, though. Not having all of the monitoring of what was going in and out. Although, were you measuring in tidal gas concentrations at that point?
Yes, you just couldn't see that.
I was just a bit too focused.
I had a sheet over the screens, the monitoring screen. So Kate had to focus on the patient and use her eyes, her ears, and her fingertips as the monitors, which is what most people that we're referring to in these environments, that's all they have.
And so for someone like me who's never used draw-over anaesthesia and is not a trainee or fellow in Australia and New Zealand, could I do this course or do I need more?
No, you absolutely could. There is a British version, which is run out of Oxford, and that's run in Kampala each year. What's unique about our course is that we actually take the course participants into operating theatres where they use the draw-over equipment for patient inductions. And that's unique. That's what stands our course apart. Right. It's also why it's a lot of work. But it's a fabulous course. And so we had many snapshots on Friday for about 50 of the Congress participants. And we introduced some topics which Rob is going to expand on tomorrow when he delivers his plenary talk.
Can you tell us, give us a preview of your plenary?
Yeah, yes, Kate. So I've been... it's great that global health has been included in a plenary session on perioperative care tomorrow. So I'm being asked to give a global perspective, and it's challenging to talk about a topic when you realise that 5 billion of the world's population doesn't have access to safe and affordable surgery and anaesthesia. Now, a lot of the reasons for this is workforce. So there just aren't enough anaesthesia providers, let alone specialist anaesthesiologists in many countries of the world. So I'll be presenting our progress towards achieving various targets that were set by the Lancet Commission on Global Surgery in 2015. Now, many people there will have heard about these figures, so I'll be giving an update, but it's not all about workforce. It is about quality of care, but you can't start thinking about quality of care until you've got sufficient workforce to start thinking about these things. So there is some good news. I'll be talking about the rapid improvement in anaesthesia in Mongolia over the last 10 to 15 years, of which our college has had so much to do with, which has been a fantastic partnership with a number of organisations, including, and probably most importantly, the Mongolian Society of Anaesthesiologists. So I'll talk a little bit about quality of care, but I'm also going to talk about the war on drugs. So we're all aware of the war on drugs, but there is a war on drugs in the anaesthesia community. For example, there have been various moves over the last 5 or 6 years from some countries at WHO and World Health Assembly level to restrict access to really important drugs like morphine and ketamine. And we've got to be on guard against restricting access to those medications. But even other anaesthesia medications like halothane is surprisingly still one of the most widely used agents. The biggest halothane producer in the world shut down production in Bangladesh at the end of last year, and that's created potentially a crisis around the world, and we need to work out where to next. When I say we, that's collectively the anaesthesia community, so I'll be talking a little bit about that. And I'm going to ask the question, an ampule of propofol, which costs 91 cents in a hospital in Melbourne, why does it cost $30 for one ampule in Port Moresby in Papua New Guinea?
The same thing applies to ondansetron, with 20 cents in Australia and $1.20 in South Sudan.
Mm.
It's what are the reasons for it?
Well, I think there are obviously supply chain issues, but what we have is the advantage of purchasing power. So our governments and ministries of health and hospitals can go and say to the people who sell them, we want this, but we want it at this price. You can't do that in South Sudan. You can't do that in many countries. And there's also a quality issue for medications as well. Since the cessation of halothane in Bangladesh, there have been a number of deaths, probably due to adulterated halothane that other alternate suppliers who are mixing halothane with other medication or other substances are putting together, and it's a little bit like vaping. You just don't know what you're getting.
So that's fascinating to me, that the countries with less resources are expending more resource to get the same product, essentially.
Correct.
I mean, so what's the way we can facilitate breaking that barrier down, or the way around that? Are there ways around that? Or
well, yes. Firstly, there's got to be awareness. So at the moment, all I'm doing is spreading awareness, but there needs to be study. So the area is ripe for study, and there are a number of keen researchers, and already some of our colleagues in PNG, who many of whom are at this meeting, are keen to investigate this and find out exactly what the barriers are to getting anaesthesia medications at an affordable price. So, it's looking at supply chains, it's looking at purchasing powers. So there needs to be research, but we need to get our national societies, our colleges, advocating to health services, ministries, and we need to escalate this to the WHO and WHA level.
There's also other things that the college and the societies are doing about pain management. You mentioned a global war on morphine, but that's actually been waged at a local level as well, with reluctance to use potent pain relief. And Roger Gook and Wayne Morris set up, fellows of our college and faculty set up a program about that I believe has gone global.
That's the Essential Pain Management course. Chris might have a couple of words to say about it.
EPM has been an outstanding success, and I was actually in Micronesia with Wayne. We were teaching primary trauma care about nearly 20 years ago. Wayne showed me this. He put something together and he showed me this thing about a rat, and I didn't know what he was talking about, but it was recognise, assess and treat. So the whole simple message to pain management, not just anaesthesia and surgery related, but chronic and cancer pain, and it's been an outstanding success. And the college has been incredibly supportive of the concept and its development and its rollout. EPM has now been run, I think, globally in more than 50 countries around the world, and we did talk about this on Friday as well, and Rob will allude tomorrow in his plenary session, but there's still a lot that we need to do to educate, teach, advocate for and develop pain management across the world in both anaesthesia, surgery, but also in chronic and cancer pain. And EPM has done an immense amount to try and fill that gap and educate. Incredibly important work.
I mean, that sounds like a quite outstanding achievement, to be honest, for someone that wasn't aware that program was going on. But where do you feel the next big impact's going to come from? What's the next stages we should be pushing towards in this area?
In pain management?
Yeah.
Well, I think what we've managed to do is what we now need to do is we need to educate and advocate for and empower our local colleagues to step up and manage their own services in ways that they had not been able to beforehand. And so I think that is the next step. The next step is always to hand over
of course.
to those with which we work.
And does that handover process, does that need to be sort of region specific? Is that country specific, or is it more a systematic approach of how that's done in practice on the ground? How do you actually make that happen when you're visiting these places?
It's a great question, Andy, and you've got to tailor a solution for the problem in the country that exists. But it is impossible for people from outside to go and do all of this, and you've got to find local champions.
Yeah.
And once you find local champions, then you've got to support them. You've got to give them help with advocacy. In many cases, they often become much better advocates. They're going to be much more powerful advocates than we could ever be as an outsider.
Yeah, of course.
There are going to be times when things just don't work. So if you go and set up a program like EPM and primary trauma care before it, there are failures. You've got to accept those failures and move on. There's a lot of need. And once you get a team who are willing to take it on, then the results can be astounding.
So a lot of people want to go on global health trips, and increasingly departments are arranging electives for their students or for their trainees to experience global health. And we were discussing before this interview about, what's the real purpose of going on a trip? Is it to help people in a community, or is it to grow as a person, or is there anything that you can learn overseas that you can bring back to a hospital in the middle of Melbourne and make a difference to patients in Australia? Chris, have you got any thoughts about that?
I might start, and then Rob can add his thoughts. But I think that this is very much a mutually beneficial arrangement. So we are often seen as the experts when we come and work in these sorts of countries. But in actual fact, we're bringing some knowledge and some skills that we will then teach. But I can assure you that we probably learn more from those that we work with. The people that we do work with, anaesthetists, surgeons, nursing staff, young doctors, medical students, they've all got things that we learn a lot from. How to deal with living and working in a much less privileged environment and country than we have. And I think it's really important that young clinicians or any clinician from our environment should have the opportunity to go and work and see and learn from those in these countries. It's very much mutually beneficial as far as I'm concerned. I get a lot more out of working with the people that I've got to know over the last couple of decades. They've taught me a lot.
How about you, Rob?
Oh, yeah, I agree. I was just astounded when I first met Dr. Kiney from the Solomon Islands, and to think that he left his village for primary school to go to the next town to go to high school, and then was considered an academic achiever, and then would move to the capital city of Honiara to go to high school, and then go to Port Moresby to go to university and study medicine. And then specialised in anaesthesia. Then went back to Honiara. By that stage, he's speaking 7 languages, and English is about his 3rd language, which he speaks beautifully. And he's lived his life and worked in the Solomon Islands, and the knowledge that he has, the teaching skills that he has, the mentoring skills that he has are just immense. You can learn so much from people. So, that has been my experience. I would say that if you're looking to start out getting involved in global health, you need to really pick the organisation that you get involved with. So if it's a service trip that you're looking for, then really look at the organisation you're going with and make sure that they've got strong charter of expectations and how they partner with locals. And we're very fortunate to have a number of people who run great service trips that really are in partnership with the local communities and the local medical communities. So the Royal Australasian College of Surgeons, Interplast Australia and New Zealand. I've had a lot to do with Smile Train recently, and they're certainly very good as well. So I'm not saying that others aren't good, but there are some that are really have thought about this. And I think our college and our societies have really thought about how we interact with educational projects as well. So
where's your next trip, Rob?
my next trip is to London for a board meeting for Lifebox.
Well, that's the third world, eh?
Yeah, absolutely. Yeah. I say, well, we had wanted to have it in Ethiopia, where Lifebox has an office, but it was just too hard to get everyone there. London was much easier to get everyone there, so I'm disappointed about that. But I am excited about going to London.
And can you do any better on the global health credentials there, Chris?
Well, I'm going to Kuala Lumpur for the Malaysian Society meeting in August, and then to Fiji for the Pacific Society meeting, which is also in August.
I've got to ask, I know we're running out of time, is before we finish, you touched really nicely, both of you, on the benefits of those connections we're forming with people in different regions and different cultures, if you like. And as part of TopMedTalk Warriors and just in these, the power of conversations we keep talking about, I think that's a really good example of that. Does it always have to be that way around? Do we always have to go and visit them? And is there any benefit in them coming to visit us? And is there any progress with that in the college facilitating that?
So there are 4 Papua New Guinean anaesthetists who are here at the Congress.
Sponsored by the college?
Sponsored by the college. The college have been incredibly generous in facilitating opportunities for young anaesthetists from Papua New Guinea and the broader Pacific to attend major meetings like the World Congress in Singapore recently. And I think that's incredibly important because they will come here. What's most important is they meet people and build networks, and it's about communication. And they'll take other little pearls back home as well, but it's about the opportunity to meet people that's most important. And so I'd have to say, I think the college has been fabulous in the way in which they've supported anaesthesia, not just in Papua New Guinea, but in our Asia-Pacific region as well.
And the college should be thanking both of you for all of your hard work over many years in this space. So we look forward to your talk tomorrow, Rob, and we thank you both for coming on TopMedTalk Down Under.
Thank you for the opportunity.
Thank you.
So you can look for this interview on our website, on our socials, and also in the daily newsletter from the college. So let's keep the conversation going, Andy.
Absolutely. Thank you very much for having us again, and let's join the conversation.
TopMedTalk.
Thanks for downloading TopMedTalk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook and X. Also, it's important to remember that TopMedTalk is the broadcasting arm of EPPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is eppom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. eppom.org.